Adult scoliosis is much more common than most people realize. Now, when we think about scoliosis, a lot of people think about scoliosis in teenagers. But the reality is the prevalence of scoliosis in adults is much, much higher than the prevalence of scoliosis in teenagers. Only about 3 to 5% of children, juveniles, and adolescents are ever diagnosed with scoliosis. But when we look at adults, once someone reaches 40 years old, it's about 9% of adults get diagnosed with scoliosis. At 60, it's over 38% of adults. And once we hit 90, it's anywhere between 50, and some studies even suggest up to 68% of adults have degenerative scoliosis. Hi, I'm Dr. Chris Gubles here with Scoliosis Care Denver, Colorado. And today I want to do a deep dive into adult scoliosis, the different causes of scoliosis in adults, and what are the most effective non-surgical treatment options. Now, if you're liking this content, be sure to give us a thumbs up and hit that subscribe button so you can get informed when we have new content coming out. Now, there's different causes of scoliosis in adults. There's three main potential causes. One of those, if someone has an idiopathic scoliosis when they're younger, like an adolescent, that they still have as an adult. The second is what's known as a degenerative de novo scoliosis, which means it's a new scoliosis that actually develops in adulthood. And the other one is a secondary scoliosis in adulthood, which means there's a scoliosis that's secondary to some other health condition, possibly a neurodegenerative condition, post-surgery or post-trauma, and I'll dive into that a little bit later. Now, let's look at the first one, an adolescent idiopathic scoliosis present in adult. We call this ASA, adolescent scoliosis as an adult. Now, when we look at people, scoliosis most frequently develops in adolescence during growth spurts. It can happen as a juvenile, which would mean someone's between the ages of 3 and 10, but most frequently it happens at the onset of puberty. Now, we don't know exactly what causes scoliosis, hence the words idiopathic means no known cause, but there are some theories, and we know it's likely some genetic factors along with some environmental influences that triggers some of the genes to turn on. And when that happens, the inside or part of the vertebrae grows slower and part of the vertebrae goes faster. That causes the spine to start to twist and rotate. If that curve gets large enough, let's say over 20 degrees, then there's actually more pressure on the inside of the curve, and that extra pressure can actually slow the growth. There's a law called the Hoover-Volkmann's principle, which actually means when you put pressure on a growth plate, it stunts or slows the growth. So in an adolescent, when you have a curve that starts to get over 20 degrees, you have extra pressure on the inside of those joints. That again, along with the abnormal growth, causes more abnormal growth and the spine can progress. Now, when you're looking at adolescence, there's a couple of big numbers we're paying attention to, 30 and 50. Once a curve gets beyond 30 degrees, it has an increased likelihood that it could continue to progress after skeletal maturity or in adulthood. Once a curve gets beyond 50 degrees, it's pretty much a consensus that curve is big enough that it will absolutely 100% continue to progress after skeletal maturity in adulthood. Now, it's not only the size of the curve we look at, there's some other things that can influence the chance of a curve progressing in adulthood too. The location of the curve is a key part because curves in the thoracic spine after skeletal maturity or when someone's done growing are less likely to continue to grow as compared to curves in the thoracolumbar spine or the lumbar spine. The reason for this is the rib cage can help stabilize curves in the thoracic spine to some degree, but you don't have that same supporting stability in the thoracolumbar or lumbar spine. So location makes a difference too. Then there can be other things like an anatomical short leg or sacral obliquity that can also contribute to an adolescent curve continue to progress in adulthood. So when someone's growing, the spine is actually growing asymmetrical. But when someone's done growing, the continued progression of that curve is a degenerative process. So basically an idiopathic curve starts to get a postural collapse, you get asymmetries, you get asymmetrical pressure on the disc and the joints, the part that has more pressure breaks down, decays, and a curve progresses. Now, a degenerative de novo scoliosis actually begins or starts in adulthood. Now, in women, this typically begins after about 50 years of age or after menopause with change of hormones and things like that. In men, it typically develops a little bit later, around 60, 70 years old and beyond. This is also a degenerative condition. And typically what happens is there's some asymmetries in the body It causes abnormal wear on the one part of the disc in the facet joints, which causes some asymmetries, which causes more asymmetrical loading on those joints, and the spine continues to break down and decay. Now, we don't always know when someone comes in as an adult if they had an idiopathic scoliosis that's progressing, or if they have a de novo or a new scoliosis, if we don't have any records or prior x-rays when they were younger. But a lot of times we can tell that the curves or like the pattern that we see in a de novo scoliosis is a bit different than an idiopathic scoliosis. One of the things we see when someone has a de novo scoliosis is they start to get a lateral collapse. They start to have a curve at a certain, generally it's always the thoracolumbar or lumbar spine, and they start to collapse to one side and they really start to hunch and lean forward. Now, that can happen in idiopathic scoliosis, but the pattern we look for is a little bit different, and there's some distinct things that a skilled practitioner can pick up. Why it's important to know is a de novo scoliosis is generally more progressive or progresses at a faster and higher rate than an idiopathic scoliosis. And both of these curves tend to progress and snowball and progress faster later on in life, or over time the curve progresses faster, it picks up steam. And the last type of scoliosis that can be present in adult is a secondary scoliosis, a scoliosis secondary to some other health condition. Now, one of these can be secondary to a neurodegenerative condition such as Parkinson's disease or Alzheimer's. Another secondary cause of scoliosis can be an underlying metabolic condition such as osteoporosis, weakening of the bones, or possibly from a fracture in a vertebrae. Post-surgical things can actually happen, like after a fusion, you can have what's called adjacent segment disease, where the segments above or below a fusion can break down, decay, and lead to scoliosis, or possibly after a hip replacement surgery or a laminectomy with weakening of the connective tissues, that could lead to potential scoliosis. And then biomechanical factors like having an anatomical short leg or a pelvic obliquity, which is basically a misshaped pelvis or sacrum, which is where the spine sits on, or possible hip pathology. And, you know, if the surface of the spine is not sitting on a level surface, that can perpetuate or cause a scoliosis to progress or develop secondarily to an anatomical short leg or a pelvic obliquity. In adults, the biggest driver of someone seeking treatment is actually pain. Pain tends to be the thing that people are most concerned of. And when you look at pain in an adult with scoliosis, the pain patterns are a little different than an adult with back pain that does not have scoliosis. For example, an adult that does not have scoliosis typically develops low back pain in the very lower part of the spine, typically L4, L5, and the sacrum, and that's generally in the center, and they may get radiating pain down the back of the leg known as sciatica. When someone has scoliosis, typically the pain is asymmetrical. It's generally on the side of the curve, and the pain is generally at its highest at the peak or the apex of that curve. Also, in scoliosis, a lot of times adults develop radicular symptoms down the side of the thigh or in the anterior portion of the thigh because the nerves that are most impacted are higher, like around L1, 2, or 3, where the peak of the curve most likely is. So let's take a look at a little bit deeper dive into what this looks like. As mentioned previously, the main problems associated with adults with scoliosis is pain, disability. Disability is when someone can't physically or functionally do things they would normally do in their life. Progression, fear of it progressing, getting worse, and then also aesthetics, or how someone actually looks on the outside. Now let's take a look at a great case, and this is a great example of an adult de novo scoliosis, a scoliosis that actually develops in adulthood. This case right here in this picture, this is a 48-year-old nurse that presented with her to her primary care physician who was having back pain. And they just recommended doing pain meds, and they said there was no big concern. When you look at this from the front, you don't really see any potential signs of scoliosis. From the side, there's nothing staggering except for there is a loss of the normal lumbar curve. That curve is reduced. Then let's look at this patient returned 9 years later in 2013. She had more severe back pain, and now you can actually see that scoliosis beginning to develop in her spine. And you can also see there's even more loss of the normal curve. Now it took 9 years to go from here to here. But After 2013, she returned in 2015, and you can see this curve even continues to progress and get more severe. You can see the inside of the disc are severely degenerated, and it's a little hard to see the facet joints, but those are the joints in the back on the inside of the spine. Those have more severe damage and arthritis as well. Also, she's starting to develop a lateral listhesis, or a lateral slipping of the vertebrae. If you look down here at L4 compared to L5, the vertebrae shifts off to the side, which tells us that spine has become unstable and the ligaments can no longer keep the vertebrae in proper alignment. And she's actually developing a reversal of the lordosis. She has a kyphotic curve in her lumbar spine, so it's more unstable. And then just look from 2015 to 2016, you can see her curve even continues to progress and get more severe. So this is an excellent example of an adult de novo scoliosis that developed in a woman after menopause. It started off slow, and you can see over time it rapidly progressed and started to progress faster and faster over time. This is a great model that shows you how the curves going from when someone's 50 to 70 starts to increase in progression, and when they get later in life, that progression rapidly increases and takes off. So let's look at some different treatments. And the first one we're going to talk about is scoliosis-specific exercise. Now, this is a paper. It was actually a cohort review looking at a group of patients that actually were candidates for surgery, that rejected surgery, and opted in to do scoliosis-specific exercise. Now, they looked at 34 different patients. And for these patients to be considered in this study, they had to have demonstrated that their curve was progressing, or the curves had to be at least over 40 degrees, which is pretty severe. Now, when they looked at this, 68% of the patients actually had a reduction in the size of their curve. And then even more of those had just no progression. Only 3% had a progression of the curve of more than 5 degrees, which is important because when we look at curves, when we're measuring the curves, we need to see there's about a 3 to 5 degree error when you measure, just a little change here or there. So we have to see at least 5 degrees in improvement or worsening to say that there was actually true change. But this was a great example how these adults, they looked at them after 2 years on average of doing scoliosis-specific exercise, and they found that 68% actually had a reduction in the size of the curve and had successful outcomes. This is a graph from that study, and on the left side of this, you can actually see the line that's going up. This is the curve actually progressing over time. And then right where that dotted line is, you can see that's when they actually started doing scoliosis-specific exercise. And then the majority of those curves either progressed less rapidly or did not progress at all. And in many cases actually got better, or they actually had a reduction in the size of the curve. Now, the other treatment we want to look at is, custom bracing or bracing in adults with scoliosis. So we're going to look at two different papers. This first one is a systematic review. A systematic review is basically a study when they look at all the literature on a subject and they look at papers that meet within certain guidelines. Within this study, they came down to looking at 10 different papers. And when they looked at these papers, it was anything from soft bracing to hard bracing. And there was some mixed results, but overall what they found is that the braces were most effective at reducing pain. It was also the number one reason people got the braces because they were having pain associated with scoliosis in adulthood. But most people found modest to significant reduction in pain levels when they wore a brace that was specific to their scoliosis. Some other findings were that sometimes they had modest or significant reduction in the size of the curves. Sometimes that they had a decrease in progression of the curves, meaning it stopped the curve from getting worse. And then sometimes, in a few cases, the curves still continue to progress. Now, it's important to know the papers use different kinds of braces. In a couple of the papers, they were using a soft brace. And then in the other papers, they were using a more rigid brace. And you're obviously going to get a different result with a rigid brace than you will a soft brace in treating adults, especially as the curves get bigger and more severe. Now, this is one of my favorite papers. And this is a really interesting paper. And in this paper, the authors looked at a group of adults with scoliosis. And they looked at them over a 15-year time frame. Now, in the first 10 years, the patients got no treatment. And they just observed the patients, and they found the average patient's curve got 15 degrees worse over 10 years with no treatment. On average, about 1.5 degrees worse per year. Then the last 5 years, they had them wear a custom LSO, lumbar sacral orthosis, or a custom scoliosis brace for their scoliosis, and they wore that between 4 to 6 hours a day. And when they started wearing the brace over the last 5 years, the average patient's curve only got 0.2 degrees worse per year, or 1 degree worse over 5 years. So the average patient went from the curve getting 1.5 degrees worse per year down to only 0.2 degrees worse per year. Or in other words, the average patient got 15 degrees worse over the first 10 years when they weren't wearing a brace, and they only got 1 degree worse over the next 5 years when they were wearing a brace, only 4 to 6 hours. So we know these braces are highly effective at slowing the progression of curves, reducing the curves in some cases, and in almost all cases, of the majority, reducing or dramatically reducing overall pain levels. Now, the goals of non-surgical treatment, scoliosis-specific exercise, and bracing is the same goals as surgery. It's to reduce pain, to allow someone to do normal activities of daily living, to stop or dramatically slow the rate of progression. So if the goal of a non-surgical treatment is the same as the goal of a surgical treatment, which is much more invasive, has much higher risk of negative consequences, increased risk of morbidity, even mortality, you always want to exhaust non-surgical treatment options first. And then if those treatment options do not succeed, then you can always opt in for surgery. Plus, many adults are not great candidates for surgery because as your bones get thinner and weaker with like osteoporosis, they're not as good at holding screws that may be put in pedicles for surgery. Plus, as you get older, you don't recover as well. You have increased risk of infection, and really just all causes morbidity from surgery. So a quick recap, there are different causes of scoliosis in adulthood. You could have a scoliosis that you had when you were younger, that you still have as an adult, and it progresses and gets more severe, more painful. You could have a new degenerative scoliosis that develops in adulthood, and you could have scoliosis that's secondary to some underlying pathology like a metabolic condition or a neurodegenerative disease. Regardless of the cause, or the treatment is basically the same. And there's 2 treatments that we have found effective at treating scoliosis in adults. One of those is scoliosis-specific exercise. Now at Scolio-Care, we use something called ScoliBalance, which combines some of the most effective methods out there, and we take the best and most important parts and apply those to each patient based on their case. And then there's also custom bracing. Now at Scolio-Care, we use ScoliBrace, and I believe ScoliBrace is the best brace available because it's one of the only braces that's true customized for each patient. It has a 3-dimensional design, and we use CAD/CAM technology, or computer-aided design and computer-aided manufacturing, which allows us to take the human error out of how a brace is designed and made, so we can make sure each patient gets the perfect brace for their individual case. So if you're watching this and you have scoliosis as an adult and you're looking for possible treatments, give our office a call or click on the link below and request a free discovery call. And this is the chance to speak with me for 15 minutes where we'll do a consultation and we'll go over your specific spine and your case, and we'll discuss what treatment options may be effective for you. Now, if you found this information helpful, be sure to hit that subscribe button so you can be notified when we release new content on non-surgical treatment options for scoliosis and hyperkyphosis.